Today we are going to talk about the clinical audit tool, or CAT4 as it's called now. The clinical audit tool has been around for quite a long time, probably about 7 or 8 years now. It has grown a lot in functionality since then, and what's been happening since last year in particular is that we have included links to the other components of our CAT Plus suite. So what we can do now is link functionality from the CAT tool to Topbar, and of course, as you're probably all aware, the data aggregation tool PenCAT, which collects de-identified data that's coming from the clinical audit tool from CAT4 that the PHN can use for their needs assessments, for their reports on the catchment, and so on. But today we're going to look at really CAT4 in the general practice setting, what you can get out of it, what is it about, what does it actually do, and of course also I'll go over basic functionality, and I will also give you some examples for which I hope will be useful reports and filters and so on. So when you log on to CAT, what I've just done, the first screen that comes up is this so-called dashboard. On here, and just very quickly, there's a number of links there, or a number of ways to access the actual user interface, and I just want to go over that. So we have CAT4 on top here, the suitcase, the full bag. That's everything. When we released this version 4, before that you only had one option, you got all the reports. But what we introduced with the CAT4, with this dashboard, is you can also go into a limited range of reports. So rather than looking at the full range, you can look at just the daily ones, sort of things that are frequently used. Chronic disease management, in particular for diabetes, cardiovascular disease, and kidney disease, cleansing view, indigenous quality improvement, and registrar view. If you're not sure what you actually want to do with CAT, I would recommend to go to the full view, to CAT4, and you can see there's all this report. I haven't loaded any data yet, but there's lots of tabs up here, so there's a couple more. And a lot of these have, then if you say on the pathology tab, you can see there's lipids, there's EGFR, and under lipids again we have the breakdown. So it all works with tabs, and I'm just going to load some data that it doesn't look so empty. That's really the full view, as I said. Now you can go back to the dashboard and say if you just want to work with a limited range of reports, and you know that's all you need. The daily view, I'm just going to click on that. So you can see now we have about 13 or 14 reports here, quite a lot less. But these are the ones that at least we feel are used most in terms of the daily business in general practice. Saying that, daily view, most people do not use CAT on a daily basis. You know, it is a tool that is something that normally around reporting that might be used once every fortnight, or maybe even only once a month. In a lot of practices, sort of in the old days, because we had a lot of reports around accreditation, they were the ones, or quite a few practices were, every 3 years when accreditation came around, they were like, oh, we better start up CAT to have a look at our smoking data and allergy data and so on. So I think things have changed quite a bit from there, because there is, for one, there's more reports in CAT now, but there's also a lot more things that you can possibly use in, maybe not daily, but more frequently than every 3 years, to pull out of your clinical system. It's gone along with the number of patients. So the clinic database is growing. People have more and more patients. Some of the clinics are incredibly big with 20, 30, 50,000 patient records in there. And it just makes it very difficult when you have that many patients in there to just know everything about every patient. I'd say it's impossible anyway. So these reporting tools like CAT are very useful in bringing out the important things and allowing you to filter down, and we'll go over that straight away. But just before, on the right hand side is the useful links, and I just wanted to mention two of them: the user documentation and the CAT recipes. So if you click on user documentation, that will get you straight in the functionality guide for CAT, which it's part of our overall help website. Those of you who logged on last week with the Topbar session, I think I did show the same there. But you can see here are the individual chapters for the CAT guide. So if you wanted to know how the filtering works, you could click on data filtering, and that will give you a summary on each of the filter tab, and it will also show you examples for that, and you know, how to change filter, how to clear filter, and then it will go over every single individual filter tab. So we've got the medical conditions filtering, and it will go over these with examples in here, and so on. So there's quite a lot in there in the user guides. And the other thing was the link to the recipes in here. What we've done with the recipes, we're basically giving you step-by-step guides how to do certain things, and they're ordered. There's headings here: improve quality of care, identify patients at risk, maximize business potential, improve data quality. So if we go to say to the patients at risk, you can see the titles there. So I hope the titles are, you know, meaningful as they are. If you have ideas for other things that you would like to use CAT for, and you're not sure how to do that, let me know via the PHN or contact our support desk directly. We're very happy to add. We've added about 20 new ones in the last 2 months, and the plan is whenever someone contacts us with an idea for a useful search, or you know, a recipe for something in particular, we just put it up there. It doesn't take very long, and that way it can be shared amongst all users. So say if you wanted to find out coronary heart disease patients who are not on antithrombotic drugs, we can click on there, it will load the recipe, it will tell you a bit about it, the title, why do we do that, who are we targeting in here, as in all active patients on the system that have been diagnosed with coronary heart disease. And then it will step you through how to do that. Go to the filter, the conditions, chronic, select coronary heart disease. Sorry, someone's typing here. You can see there that that's been selected already for you. You get the red box around. Then under the medications, we select the no, and so on. So that will really give you the idea of exactly how to get to the right result to bring up the patients that you're interested in. And at the end, you will have a list of people there with their names and details. Might not be identified obviously in here, but you will get the real names of your patients and the other details. And you can export that list. You could also create a prompt to display in Topbar. So this is a new functionality that came in May this year, and it's not that widely used yet. And hi Marie, you would be on mute if you just joined. So if you have a question, *7 will unmute your phone. Otherwise, we'll stay there. I'll break for some questions and I will unmute people. But *7 if you have a question. Yeah, so the prompts that can be created, and they're basically a custom way of communication between a person at the practice who uses CAT to say identify, in this example, what do we have? Coronary heart disease patients not on antithrombotics, and to communicate that to the clinicians, to mainly the doctors in the consult room if they're using Topbar, and you follow these steps, the doctors will receive a prompt that says, please review the medication, or whatever the issue was that you looked at. We'll go over that in a minute, but that's really our help website here, and you can see there's CAT4 and there's Topbar. You're very welcome to have a browse there if you like it. But direct links come from the dashboard here. And there's also a link to our webinars. This is obviously a custom session for Darling Downs West Moreton Medical Local, or PHN, sorry. But we also run twice a week a session for CAT on Thursdays at 1 p.m. and Topbar on Tuesday. And they're free. You don't have to register or anything. All you need to do is go to the website on the day, click on that link, and it will get you straight in. And we're using the same audio connection that we're using now. Now, having said all of that, let's get actually into CAT. So the dashboard, as I said before, you can switch between different views. Once you're in, and I will be using the full CAT4 view just so I can show you a lot of the reports, or at least several. Then you can always switch back and forth if you want. But as I said, for new users of CAT, I would recommend to go to the CAT4, to the full view, and just explore a bit, because if you don't know that the reports exist, you might never use them. So this way at least you see the full range. So for the new users, and I believe there's several around, new or coming users, just some really basic ways of how to interact with this tool. Firstly, CAT is an extraction tool, so it does pull data out from your clinical system. We have the full range of reports available from Medical Director, Best Practice, and ZMed. For the smaller systems, there's not everything available. Mainly because the extractors are not built into CAT, they're built externally, in the clinical systems, and unfortunately not all of them are getting updates as frequently as we have for the ones that we have integrated, being MD, Best Practice, and ZMed. So if there's anyone in the session that's using a different system from those three, most of the things around chronic disease and accreditation are available, but it's not everything, or particularly the newer reports. I've actually just added something on our help site that might be useful. In the CAT guides, there is, under the installation guide, there is something called the under system requirements, clinical and billing system compatibility. So we put up a little matrix in here, and these ones are just generally which systems do we actually work with. But this one here actually shows you which reports are available or not available from the individual clinical systems. You can see Genie unfortunately has quite a lot that are not available there. MD, Best Practice, and ZMed, as I said, have all of these available on top of what's not mentioned in the list. But have a look there, that will tell you the details if you're using a different system. So when I said it's an extraction system, CAT pulls out the data from your clinical system. When you hit that collect button up here, it will tell you you're about to collect new data. It may take some time, depending on the size of your database, mainly. How many patients do you have in your on your records? If you have 5,000 patients, it probably takes around the 10-minute mark. If you have 50,000, it probably will take an hour or 1.5 hours. If you're in a really large clinic, we do not recommend to do a collect during business hours because, as you can appreciate, CAT will go through the whole database trying to extract all the data, and that puts more strain on your server, which means that it can slow down the clinical system at that time. So if it's a 5-minute or 10-minute job, then there's no problem because not that many patients will be opened up in that time. But like I said, if you're in a very large clinic, it's better to do this after hours. And we also have something called the scheduler, which allows you to do automatic collects, and they would be normally scheduled to be run 2 o'clock in the morning or something after business hours, so they don't have any impact on the server performance. So once you have the data collected, the extracts will show in this panel here called the extract panel. You can see I've got one loaded here. Normally you would always load the most recent one. But I have this is just my little demo system with 64 patients or so. So I've loaded our de-identified demo data from June, which has 8,334. So the number in the middle is actually the number of patients in the extract. And these patients are only those that are not marked as archived or deceased in your clinical system. So if you find that you might not have archived anyone in your clinical system, and you get large numbers in the CAT extract, and you look at the reports and they all look fairly, not much data in there, lots of missing information, it might be a good idea to do a cleanup in your clinical system, archive patients that haven't been to the clinic, say in the last 3 years, and do a new collect, and you will see the equivalent of what happened here. You can see that second from the bottom, 17th of December in 2013, they had more than 9,000 patients. 6 months later, we had a new data set, and we've lost 2,500. So that was a big archive, a big cleanup they did, and it's been growing since then. Really, normally, the recommended process is to do that more frequently than only once every several years, because if you keep on top, that means reports that you're looking at, the data you're looking at, will actually be more accurate, more meaningful. And that's not just for some, obscure general data quality thing. It is actually also to work at your clinic level, to work with more accurate data, which will be helpful. So once you've loaded the data, hide extracts will get rid of the panel, give you more space on the screen for the filters and the reports. So this top part of my screen now, that's where all the filter panels and tabs are hiding. And at the bottom we have a report. So I'm just going to hide the filter to show you an example here. So we're looking at, say, our allergy status that's recorded or not. And this, to my knowledge, that should actually work with any system. If there's something entered in the allergy status, then it should pull it out. This is not about coded or not. It is just about, has that person got information entered, or does it just say no known allergies? So in my example here, we get more than 5,500 people with no known allergies. We have 876 with nothing recorded, and we have the 1897 that have an allergy recorded. All CAT reports do the same. You can double click on here, and that will bring up a list of the patient details, so the patient re-identification report. And because I clicked or double clicked on the not recorded, that's what it shows me here. They all have the same not recorded information. If I do the same thing on, say, the blood pressure report under measures, and I'm interested in the 24 people here with incomplete data, you can double click on there, and it does the same thing. It shows me those 24 people. It shows me when it was measured, and in this case, because they're incomplete, what's missing basically. So you can see there, most of them, oh well, most of them have a systolic missing, but some the other way around. So that would be an example there. Or of course, if you're interested in the 642 people with high blood pressure, same thing applies. You can double click. If you want to pull out more than one part of the graph, say the elevated and high blood pressure, you can't double click. You need to use that export button in the top right, and that will now combine, and we have more than 1,700 people with blood pressure higher than 130 over 80 basically. And you can see the last two columns show the actual result, and also when it was entered into your clinical system. That's the same for pretty much all of these reports. They are mainly pie charts. We do have quite a few bar charts as well, like with the disease cases here, it's called, so you can see 158 diabetes type 2 diagnosis, 776 people with asthma, and so on. So that's one of the bar charts, but the same thing applies. If you want to know who are the 82 people with the diagnosis of a stroke, you get their names and details, and you get the diagnosis here as well. So that's the same across the board. Now, if we're looking at a report under the pathology tab, the HbA1c, I'm sure you're all familiar with that one, mainly used or really only used for measuring diabetics and how well or not so well they control their blood sugar. So we can look at this report as it is, and you notice it looks pretty useless really. We can say that more than 7,200 people had no HbA1c recorded, but what we're interested in is not all 8,334 people. And this is really the key of how to use CAT, that you need to think about who's the population that we're interested in first, apply a filter, and then look at the report. So in this case, because it is a pathology test for diabetics, we go to the condition filter, and I'll go over these filters in a minute. I just wanted to show you the principle. You can see we have diabetes here, we have other chronic disease headings, and then individual diagnosis as well. So we'll just go and say diabetes is yes. Whenever you apply a filter in CAT, you need to recalculate. This is a button on the top right. It will turn red, or the label will turn red, indicating that you've changed something in the filter, but it hasn't been applied yet. You can hide the filters first, doesn't make any difference. You could also add something else. You could say, I only want active patients, those with at least 3 visits in 2 years, and I'll come back to that one as well. You could put in a certain age range only, or gender, but CAT won't do anything until you actually click the recalculate button. So we'll do that now. And now suddenly this report looks a lot more meaningful. Instead of looking at all 8,300 patients, we only look at those people with diabetes, and we have 181. So you can always see that in that line above here, filtering by condition is diabetes and active patients, meaning at least 3 visits in the last 2 years to your practice. So this is really, depending on what you're after, but this is a definitely more meaningful report than we had before. Now, the way CAT works, once you apply a filter, that means now all of the reports that you can see up top here are now only for those 181 diabetic patients with at least 3 visits in the last 2 years, and you can see their smoking status, you can see their allergy status. You can also look at other measures such as their blood pressures, and say if you're interested in comorbidities, you can look at that disease report. You can see 154 have type 2 diabetes, 26 have type 1, 6 have, we don't know, they have a coded diagnosis of diabetes, but it's not clear if it's type 2 or type 1. And you can see 96 of those 181 also have hypertension, 72 have hyperlipidemia, and so on. So it gives you an idea of what else has been diagnosed, what other problems do these 181 people have, at least if it's been recorded in your system, of course. So that's a very basic example for a filter, but it is something that for one is used quite a bit. And secondly, I hope it explains the principle. So we are filtering down, we have our population, in this case patients with diabetes, and 3 visits in 2 years. Now all the reports show you whatever you click on, if it's around pathology results, if it's around the allergy status and so on, it's only about those 181 people. So I'll just go over, actually let me unmute you. So you're all back online. Any questions about this basic filtering so far? No? Everyone? Fantastic. We'll keep going. I'll mute you and we'll have another opportunity for a quick question soon. So you're back on mute. With the different filter tabs, and as I said before, you can add as much as you want or as little as you need. It really is up to you, and that's where I could give you lots of examples, but ultimately it is the clinical question that's coming from you that determines which filters to use, and of course also which reports to use. So the process should always be, who are we looking for? Are there people of a certain age? Are there people with certain disease conditions or taking medications, whatever it is? And then once you determine that, then you need to think about, what do we want to know? Do we want to know about the pathology results? Do we want to know about some measures such as blood pressures, weights and heights, BMIs, the immunizations, the MBS items? So all of these reports below will show you that. Just a couple of things with the filters. So if you want to find people without gender entered, the other tab will help you with that. If you want to find people without a date of birth entered, then no age option here will bring those up. The active tab in here or the option that I mentioned before, it is used a lot because people are used to this in the context of accreditation, where they normally are interested, say, in the allergy status of the active patient population only, which makes sense. You're saying that people that come at least 3 times in 2 years, they normally are the ones that are seeing your practice, that you're providing their normal care. So you should have fairly good records for those patients. But if you're looking for other things like patients at risk, then this might well not be the right thing to do. Just a couple of examples. People that have just joined, been new patients at your practice, they might not have 3 visits in 2 years. They might be quite sick and they might have multiple chronic problems. They moved to the area 2 months ago. They already had 2 visits, but they didn't have 3 visits. So by clicking the box for a search for someone, say, who had a high blood pressure or high HbA1c or whatever you're looking for, if you always click that box, you will miss out on those new patients. The other example is that there are always people that should see the doctors, should see someone in general practice, but they don't. And men are particularly, the culprits there, young and healthy, at least until they're 50 or older, and they don't go and see doctors regularly. And if you untick that box, if you tick the box, if you only bring up people with 3 visits, you're bound to not find people that possibly would benefit from actually being recalled or being seen. Maybe because of preventative action around Medicare items, health checks and so on, but also if they already have an existing condition, but they're just not getting their checkups done. So just keep that in mind. I'm not saying you can't use it, but it's just something that is potentially making you miss out, or making the patients miss out on checks if you're using that filter all the time. Now, I'll just go quickly through these tabs here. Ethnicity is, I think, pretty straightforward. If you tick the top one, it's just all Indigenous patients. or if you want to be more specific, you could just find Aboriginal patients or the other options in there. Same with the ones above. Under the conditions tab, we already used that diabetes. Just a couple of things. When you tick the yes on top, as I've done, that means any type of diabetes. If you look down here, we have the type 2, the type 1, and the undefined. If you want to be more specific, you could say, we just want patients with type 2 diabetes, and recalculate. And you can see now, firstly, we've lost all the undefined ones. Secondly, there's only 154 patients, and obviously that matches the number in here. But what we can also see is that we have 5 people out of those 154 that also have a type 1 diagnosis, because we only filtered for the type 2. So every single one of the 154 patients does have a quota diagnosis for type 2. Interestingly, 5 have type 1. You can confirm that by ticking both. So if you go below the line, rather than ticking yes on top, which will be type 1 or type 2, if you go below the line and tick type 1 and type 2, it is an AND search, and it will only bring up those patients that have both. And you can see there is my 5. Shouldn't be anyone with both diagnoses, but this is what we find. So it's another quick little step to actually clean up your diabetes register, because really there should only be one of the two, and clearly there's a wrong diagnosis in there. If you go up top here again, and we have bringing up all people with any type of diabetes. Sorry, I meant to talk about this one before. This sometimes confuses people a bit. Undefined diabetes in this context means anyone with a coded diagnosis of diabetes, but not a type 1 or type 2 coded diagnosis. If it's a free text diagnosis, anything that is not coded, we don't pick it up, we don't report on it, we do not even know it exists, which, by the way, applies to your clinical system as well. So if you have doctors that put in free text diagnosis into your clinical system, let's say they type in diabetes and then they put a comment behind it or something, that's enough for the clinical system to not recognize that it is a coded diagnosis. And that means obviously we can't see that either, but it will also disable all of those internal warnings. There's some drug interactions for people with diabetes, for example, that are not picked up. It won't be able to give you a correct count of how many diabetics you actually have, which affects your sick payments, and so on. So there's quite a few reasons why the coded diagnosis is really good. But then the next step is make it a clear, in this case, a type 2 or type 1. Don't just say it's diabetes, full stop. Coded, yes, but it's not clear what it is. So to find this, you could do the same thing. And you can see there's, in this case, only 6 patients. It is probably very easy for your doctors to look at that list and to say, well, this one's type 2, type 2, type 1, type 2, and so on. And that means someone can go in and actually update their record, and you're another step closer to a perfect diabetes register. All of these things are unfortunately not one-off. You might be able to clean up sins of the past, but it doesn't mean that there's no new uncoded or free text or whatever it is diagnoses that are entered. So it probably is worth checking, not just once, but that would be a big cleanup if you get your diabetes register up to date. Now, going back to everyone. So if I recalculate, we got 181 back. Exactly the same thing happens with the respiratory. So you can say asthma and COPD, or asthma or COPD by clicking above the line. Same for these, same for these. If you go horizontally across here, and if you say diabetes, respiratory, cardiovascular, musculoskeletal, and so on, and recalculate, we only got 9 people now. And this is because these 9 patients have any type of diabetes. They have asthma or COPD. They have at least one cardiovascular disease, at least one musculoskeletal as well. So it's an AND search, in other words, across. If you go horizontally across, you get very restrictive. If we add renal impairment, I don't know if we... So there's 4 people. Out of 8,334, only 4 patients have something out of all of these chronic problems. And so that's not probably what you were after. You might be interested in that, but yeah, most of the time that's not the right way to go about it. With the cardiovascular here, Just as an example, there's a box here for CHD or coronary heart disease. When we have choices like the CHD option there, the tick box, that's not just one diagnosis, it's actually a lot of them. So I can show you that just as an example. Under the CAT user guides, we have our data mapping. And the data mapping will tell you for your clinical system, let's say we go to best practice, will tell you exactly there what we're using out of your clinical system. Let's say we're looking for the coronary heart disease, so the conditions, and I'm just going to scroll down. There's a bit more, and then there's our mapping here. So there's COPD. So you can see coronary heart disease. Any of these coded diagnoses that are listed here will be found if you tick that box, and it's really quite a long list here. So that means you don't have to add all of these into your search. All you have to do in CAT is tick that box, and it will find any of the patients that have a diagnosis under the heading of coronary heart disease in the clinical system, as long as it's coded. And that's probably it about the conditions filter. Mental health is here. There's some others in here as well. And then the medication. And these are probably the two that I used most out of all, with the conditions and medication. So again, you have different tabs: heart medication, respiratory medication, anti-diabetic, and other. All of these have a yes and a no option. So you could find patients with diabetes that are not taking any oral hypoglycemics. Let's see how many we have. There's 72 of them, yeah, so quite a few. Or you could say they're not taking any insulin either. There's still 46 out of my 181. So yeah, there's just quite a bit to play around with these things. It really depends, again, on what you're after clinically. But you can combine condition, yes, but you can also say, I'm after people that have diabetes, say, but they do not have hypertension, and then look at the blood pressures and so on. So lots of things you can actually work with there. This one here is an important one. Let me show you why, and I'll go back to my pathology, the HbA1c report. So you can see here, we have 9 people with no HbA1c recorded. We have 7 more than 10, 20 with between 8 and 10, and so on. So if we wanted to bring up everyone with an HbA1c above 7 or higher, and we click our export, you can see their names and so on. And you also can see the result and when it was taken. With the HbA1cs, I'm sure you know, every 6 months recommended as part of the diabetes cycle of care. So it's something that should be done fairly frequently. Some might do it even more often. But what happens here is you can sort this by clicking on the little triangle here. And I've just sorted it by date. And you can see that this is actually more than 5 years old now. This is only 5.5 now. Why do we even bother reporting a result that is so old? And the reason is that when we extract data, we only pull out one result. So every time you hit that collect button, there will only be one HbA1c, there will only be one lipid result, one blood pressure. All of the things that we report on, it's one result, and it is the most recent one only. So that means if the patient had 5 HbA1cs done in the last year, last one was last week, great, that's the one that's reported in today's extract. But if they've visited every day or every month in the last 3 years, and the last HbA1c was done in 2011, well, we still only get that one because that is the most recent one. So be aware of that when you look at these results, because if you're looking at this report as it is, it looks, only 9 people have nothing recorded, and the rest you can make some statements about how many are in a healthy range or in a high range. But what you're looking at are results that potentially are quite old. So what we need to do is use that date range result filter to make this more meaningful, depending on what you're after. So you can see it tells you here it works for measurements, pathology, MBS items, which is sort of not immediately obvious, but when you think about the items that we report on, health checks once a year, or a bit more than that, reviews for the GP management plan, medication reviews, we don't report on a short or long consult. We report on recurring items, particularly around chronic disease care And if you do not look at the dates, the same as we've just looked at for the HbA1c will happen. You probably want to know who had a GP management plan claimed in the last 12 months, not 5 years ago. So we'll apply the 12-month date range filter in here. And again, we need to click recalculate for it to actually work. And you can see things have changed a bit. We still have 181 people. There's still the same diabetics that have visited 3 times in the last 2 years. But where it said 9 before with no HbA1c recorded, we now have 32. And the reason is that the people that are outside the 12-month date range, like this one here and this one and that one and that one, they are also reported under not recorded. And the 9 that never had an HbA1c recorded are listed as well. So in other words, we have actually 9 people that never had an HbA1c recorded at all, and we have 23 that did not have one recorded in the last 12 months. So it really, as I said in the beginning, it depends on your question. If you want to know who never had an HbA1c result recorded, your answer is 9. But if your question is who did not have an HbA1c recorded in the last 12 months, then it is 32. And of course, as a side effect, we now get a much more recent picture of the people with results. So we can tell that there were 32 people in the last 12 months between 7 and 8, or 16 between 8 and 10, and so on. So that's quite a useful thing as well about this date range filter. So the message really is, for most of the reports around pathology or measurements or MBS items, think about if this is a general thing you're after, as in never had this particular test done, or if you want to check, are they up to date? Because that's really what this one would do. And if you say, well, in our practice, people get their HbA1c done every 6 months, you have to, of course, apply that. And you can see it makes a huge difference. Again, we have actually 77. And remember, this is a real clinic, so this is actually something that they are clearly not on top. Or people might not come in, they might send out recall letters and the patients don't come in, but there's a lot of potential testing that hasn't been done on time, and which reflects, of course, also in diabetes SIP item payments and so on. So there's a bit more to it. Now I will just unmute you. You're back online. Any questions? Is that something that you think would be useful? In particular, like obviously we're looking at diabetes, but in general, the report so far? Fantastic. All right, we're going to look at Medicare now. So I'll hit the mute button again, and I'll show you a bit more around that. So what we've done here with the HbA1c, it can be exactly the same for patients with heart disease and their blood pressure, or for the lipid results, whatever it is, it's the same principle. You decide on particular target patients with particular problems, or whatever your target population is, and then you have a look at the report that is relevant for them. And it might be just to look at, as I said before here, who is in a healthy range. It might be who is not in a healthy range, and you might want to pull them up for medication review or whatever it is. And it could also be, of course, as part of the quality improvement program or similar, where you have certain target indicators where you say, well, we're trying to lower the blood pressure of our patients with coronary heart disease, or we want to make sure that 90% of our patients with stroke are on blood thinning medication, and so on. So all of these things you can really pull up quite easily. And I guess sometimes people say, well, why can't we do this in the clinical system? Why can't we do that in MD or best practice? In some cases you can. There is some built-in searches and so on. I'm not 100% across any of the clinical systems, because obviously I work with our products, but generally speaking, the GP systems are designed to work for the individual patients. They're designed to show the doctors and any user everything that the system has about a particular patient, and it's all on the same screen. It's got progress notes, it's got the test results, and so on. CAT is a population tool. It looks at all of your patients. And that's why we have to think about those filters to firstly narrow it down. It's not just about one person. It's about, in this case, all 8,334. So you need to be the person to decide which part of the population are we interested in, and that's where the filters come into play. And then once you decided that, you have a lot of options, and because you don't need to learn any query languages or programming or whatever, all it is a graphic user interface. You just have to click your way through to whatever you want. And I won't go over any other filters anymore. I just wanted to show, oh, actually, yeah, there is one that's always of interest. The provider filter. So we assign a provider, depending, again, it differs by clinical system. In Medical Director or for Medical Director users, we assign the provider to, or a patient to a provider based on the number of visits. So whoever of your doctors has seen that patient most in the last 18 months will be their assigned provider. So that means if you want to create a list for a particular doctor, they might say, how many of my patients are up to date or not up to date with their HbA1c or whatever it is. So you could then just say, okay, well, because my providers are all de-identified as well, so we don't know who they are, but in your case, you see your names there. So I've done this now just for my first doctor here, and you can see 53 of my patients are the ones that are mainly seen by this doctor, and that might well be the list that that particular doctor is after. So that works quite well in there, and I'll just go back to everyone. So you could go through all of them, or there's some other ways to play around with it as well. But that's generally found quite useful, and of course you can also check out, who's not entering allergy status or who's putting in free text diagnosis. If you are sort of using filters more than once, which I would always recommend, or really it's just the way the system works. It's not just a one-off. You might just want to have a look at something, but normally these things are repetitive. So looking at the up-to-date status of your diabetics and the HbA1c, it's not just a one-off because things change next month or in 3 months' time. It might be a whole different picture. This last tab allows you to save filters, and that's really a good thing to do because a couple of things. For one, you don't have to click filters together again across multiple tabs and remember every element. So for example, here we've got active asthma patients with results in the last 12 months. So I can click on that and just recalculate, and immediately we have my 574 asthmatics, and you could go, say, to spirometry, and you look at there and you find not a single one of them had any spirometry recorded in the 12 months prior to the collect. And you can switch again then to the active diabetics with results in the last 12 months by just one click and check their HbA1cs as we've done before. That means a number of things. Firstly, you're always using the same filter criteria, so there's no confusion, particularly if you do this over, say, if you every month over a year's period, you want to follow a certain group of patients and you want to see what's going on. If you're getting better at that, if you get them in on time and so on. That means if you save the filter, you do not have to remember exactly every element of it. You just have to get it right once. And then, so you create the filter first, you click Save New Filter, you give it a name, and then hit OK, and that's it. And then to restore the filter, to apply it, all you do is just click on it and recalculate. So that's time saving, and you get the same results. But it also helps for people that are not so familiar with CAT. So maybe you have one person at the clinic that's really good with it, but there's others who would like to pull some information out, but they're not quite sure how to do it. So one person can create these filters, and then it makes it a lot easier. You just say, go to the filters, click on that filter, and then go to the HbA1c report. So you don't have to think about all the other details. It's just based on a pre-saved filter. So just remember that if you start actually working with CAT, yeah, it's generally quite useful to save this. There's no limit how many you can save. The name is given by you, and you will always be able to see what are the actual criteria that are in the filter when you created it. Now, MBS items are promised. Remember, we're still looking, let me just change that. We're going to go to a 12-month date range. So we're still looking at the patients with diabetes, yeah, active patients, osteoarthritis, sorry. Must have applied the wrong filter. Let's take that one out. There's my 181. And we're looking at 12 months, from June, that's what my extract is from, back 12 months, and we're looking at the MBS items. So when you look at the bottom here, we are far from reporting all MBS items. There's no way we could do that anyway, but as I said earlier, these are really items around chronic disease. We have preventative ones like the health checks, indigenous, age-based, and so on. And of course, the GP management plan, team care arrangement, and the related reviews, medication reviews, mental health care plans or therapeutic plans, diabetes SIP items, and so on. So a number of things on there. You can see, for one, this practice has only claimed 62 GP management plans, even though they have 181 active patients with diabetes. All of these would be eligible. They have only claimed 26 diabetes SIP item payments for the 181. This was the first tab with the count. The not recorded shows you exactly that, who hasn't been recorded. So in other words, 155 did not have a diabetes SIP item recorded. I can double click on there and you can see this first person never had it recorded. Same here. And this one was last recorded in 2014 and so on. So that's something where the business, as well as getting patients, in this case the cycle of care, getting all the items done to be able to claim that payment. So there's clearly this practice could do better in terms of their Medicare takings, because we know all of these patients have presented at least 3 times and still they haven't had that item claimed. Same for the GP management plan. So there's 119 of them that we can tell by double clicking who they are. And in the last column, you can again see never recorded, last recorded in 2013, 2014, and so on. If you have a large list like this, say 119 patients, it might not be the best way to try to get all of these in, particularly the ones that never had that item recorded. That might well be because they're seeing another doctor at some other clinic and they're getting their diabetes care at that other clinic. So what you can do again is use the sorting. And you can export that from here as well. So you can export into Excel, PDF, or Word. Excel would be the preferred choice, I'd say, because you can then do your own sorting and add columns and things like that. You can use it for mail merge if you want. But just the sorting in here. So someone like the first person now, so remember our data is from 6th of June this year. So this one here is only just outside the 12 months. It was done on the 4th of June in 2015. So in other words, people with a more recent GP management plan are much more likely to actually be regularly seen at your clinic and receive the diabetes care here. So they would be the ones you'd start with recalling, rather than starting the ones like all of these people that never had their GP management plan recorded. I'm just going to see how many there are. There's quite a few. So, and even someone that last had done 10 years ago in 2006, might not be the right person to start. But that's really, again, your choice. It's just what computers are really good at, and what CAT in particular with the filters is really good at. It allows you to narrow down your target patients, to bring it down to the people that are in most need of care, or in this case, who are most likely to come in and have that you can actually claim that GP management plan, because they're not likely to have it claimed somewhere else. So it's really comes down to narrowing it down to the right patients. Again, as I said before, just going to unmute you now. Everyone's back online. Any questions to this? No? Yep, excellent. Back to mute. Actually, I'll just get you back on. How's everyone going for time? I know officially it's 3 o'clock. Do you want me to keep going? Has everyone got time, or what's the overall feeling? Yeah, I mean, if people have to go, then just that's fine. Just drop out. I won't be too much longer. I just wanted to show you the diabetes SIP item and the MBS eligibility reports, just so you get a bit of an idea around the whole MBS items a bit more. There's a couple of new things in there, and I think they might be useful. So thanks for your interest, and we'll keep going. Okay, MBS eligibility. Now these are a bit different. let me just clear the filters. What we're trying to do here, and I have been going on about this the whole time, saying that you need to filter, you need to bring down the population to the right patients only. But what we're trying to do with this particular report is to take that responsibility off, and we do the filtering for you. So all of these reports here are pre-filtered. Now, they might not be pre-filtered to 100% your preferences, and you can still add filters. So one thing you might consider is adding the active patients in there. Let me show you what that does. So currently we're looking at health assessments here. 75 plus, 45 to 49, and the 715, the indigenous health checks. So I'll just recalculate, and you can see we've lost quite a few patients now. There was more than 1,000, now we've got 740. And really the main reason for that is that a lot of these items are recommended by Medicare to be done only for your regular patients. And if you filter for people with at least 3 visits in the last 2 years, chances are that these are your regular patients, and you've probably got a better chance to get that item claimed. And that they are really patients that are not seeing too many other doctors, if any. So this one automatically filters by age. So it will tell you these are patients older than 75 with no health check 75 plus claimed in the last 12 months. These are people in the right age group 45 to 49 who never had that one claimed. And these are the indigenous patients not having claimed the check in the last 12 months. Diabetes SIP item, and we already know that from our MBS report before, but in this one we had to actually filter, whereas now it does the diabetes filter automatically, and it will tell us who are the 155 not claimed in the last 12 months for the diabetes SIP item. And last but not least, we've got the GP management plan team care arrangement in there. You can see here these are people, and we're looking not at all chronic problems, we're looking at diabetes, cardiovascular disease, and chronic kidney disease. So there's obviously others that also qualify for the GP management plans and team care arrangements, but that's just what we based it on for this. And so there's 192 people with at least 3 visits that never had this particular item or either of these claimed. There's 83 people that had a GP management plan or team care arrangement done more than 18 months ago, but they never had a review done or claimed for it. This is the same for the 18 months, but no review in the last 6 months. These are people with a GP management plan team care arrangement done in the last 12 to 18 months, but no review, never. And this one is one that's where it's more than 6 months ago. So in other words, you do not need to do anything in terms of filtering if you're after people that would be eligible for a GP management plan team care arrangement review. You got your 83 here. They're definitely certainly within, because they're way outside the 3 months range. They're more than 6 months, or never in this case. And yeah, so we've got just make it a bit easier there. But as I said, you can, and I've done that already, added the filter for active patients only, or you could run it for all of them. So that's an example for a pre-filtered report. And then, as I promised, the diabetes SIP items. Now, this one here needs a filter, because if you look at it now, we got all 4,977 in this case. They are my active patients. It's not meaningful for those, so we need to go back and add the diabetes in there. And we're back to the 181, and you can see now which items are up to date and which ones haven't. So we can see that only 2 people had a foot exam in the last 12 months, or 6 to 12 months, and 4 people had it done in the last 4 months. Yeah, CAT is not dependent on CDMNet at all. It just works with your clinical system, so that has nothing to do with it. But the information still has to be in the clinical system. So if you're using external templates or something and you don't enter information into the right field in your clinical system, then we can't extract from a CDMNet template. We only extract from the clinical system. Let me just unmute you. Marianne, does that answer your question? Yeah. Mm-hmm. Which item? Well, you still, what we're looking at for the items is your Medicare payment receipts. And you still get those through your billing system, won't you, even with CDMnet? Yep. So sorry, I probably didn't clarify that in the beginning. All of the MBS item reports that we're looking at are based on your billing system. So we're looking at what you receive from Medicare. Yeah. So I've just put you on mute again. And that applies to the MBS items here as well as the MBS eligibility, because in this one here we're also looking at obviously a never claimed and so on. And we're not looking at just a claim that's been sent in, we're actually looking at a payment that's been received rather than the claim put in. So just one more thing on this diabetes SIP item here. The last tab, the items completed per patient, that's the one that people use a lot to check what's missing. And I'll show you, this is a bit different from the other two. We've pivoted around, so we have the number of items, it's 14 all up. We have 0 patient with all 14. We have 2 people with 13, 6 with 12, 19 with 11, and so on. So when you're starting from the right, and again, this is an example for working more efficiently rather than starting on the left where we have 3 people that have nothing at all, not a single item entered as part of their cycle of care, or these 9 people with only 1 item entered and so on. These are the easy ones starting on the right. So I've highlighted 3, you could go to 4 as well, it doesn't matter. And then it's called worksheet on here, not export, because it is a worksheet. It'll show you the name of the patient and the other details, and then each of the items of the cycle of care and what's been entered and what hasn't. Now, when I say entered, please keep in mind that pathology is easy because that comes into your clinical system and we pick it up from directly. That's unless there's something funny going on with the way the pathology lab sends the data, there's no problem for us to pick that up. Blood pressure and so on, if it's entered into the right box in your clinical system, not into free text progress notes, again, no problem. Where it gets tricky, and this is everywhere the same, is the foot exam and the eye exam. I think in best practice it's a little bit easier, but I can show you very quickly in Medical Director where that's screen's open. In Medical Director, it's a bit of a journey to get there. But if it's not entered into that field, and those who were in the Topbar session last week, if people are using Topbar and looking at the diabetes cycle of care in Topbar, it will actually bring you to the right place in the clinical system, and which is in that particular case of the foot exam is a lot quicker and easier to enter it through there, because in MD there's I think about 12 clicks to get to the foot exam spot. So that's definitely an issue in terms of putting the information in the right place. So it is under diabetes record, and then it's in a new assessment. There's no other way to get there. Clicking on next, next, next. We got eye exams in here. We got the, yes, Marianne. Yeah, no, you can't do the foot exam there. If you go to add values, you see you've got lots of other things, but it's not this podiatrist. This is not where we're pulling it from. Because a foot exam is not, a visit to the podiatrist probably also has a foot exam, but the foot exam that they're actually after is something that's done at the clinic. It doesn't have to be, but that's why we don't tick it off through there. It's done a foot exam that is done and recorded as such, rather than just a podiatry visit recorded. It is something that we probably, if we say that this is ticked, that would equal a foot exam. It probably is correct, but I don't know if it's 100% if in all cases. I can make a note, actually. I meant to do this a while ago. But yeah, currently it is definitely not triggering that to be counted as a foot exam. It has to be the one through all of these steps where it actually says head foot examination. Yeah, and it is a very common thing, because mainly the main reason is it's so deep in the system that people just can't be bothered to go through all of these clicks. This picture here where most of the pathology is doing okay and the blood pressures and so on, but every clinic I've seen has this issue with the foot exam that it is really low, the count. And when you think about this here as well, so according to CAT, not a single patient has all the items done. But if you look at their MBS items, we actually had 20, were there, or 50, this is not in the last 12 months, so if I add the 12-month result in there, actually 26 people had the item claimed. So in other words, unless there's something dodgy going on, which I would never say, these 26 people were up to date with all of the items, and that's why they were claimed. It's just that we can't pick up the all of the items unless they're put into the right field in the clinical system. So that's where you also got to be aware of what's already been claimed. There's some tricks around it, but that would be taking a bit too long to do that today. But yeah, we've actually got a couple of recipes around the diabetes SIP item on our recipe site as well, so have a look there. In all cases, I'd say CAT is a tool that can help you greatly to point out where things are missing or where there's, you know, patients in need of being recalled or with results that are in a high range and so on. To fix the issues, it always goes back to the clinical system. You cannot fix anything from CAT. All we're doing is reporting. It is a clinical audit tool. It's not a tool that allows you to change things in the clinical system. We can't even write anything back. It's completely read-only, and it's 100% reliant on the data that's been entered, and not only that, it needs to be entered in the right field, and in the case of a diagnosis or similar, it needs to be entered in the right format, manually coded. So I think we'll probably have heard enough of me. I'll just unmute you again. Any questions to anything we've been talking about today? Okay. Well, thanks everyone for their time, and yeah, have a look at the recipes, have a look at our user guides, and you're also very welcome to call support. Under help, you can see in here where it says about CAT, there's our free call number, and I'm speaking for the PHN. I'm sure the practice support staff is very happy to help you as well. All right, thanks everyone, goodbye.